Thank you very much, and I want to congratulate the chairman for keeping the symposium on time. That's a very difficult thing to do. So we're going to talk about vitreomacular traction, and as many of you know, there have been some very new developments. This is my 11-year-old daughter dancing ballet in a scene from India, actually. There are many types of vitreomacular traction. Here we see a patient where we can see the traction band, we can see the retinal striae being drawn into this, and of course on OCT we see very well the traction. This is an older time domain OCT, and even with that instrument we can see very well the nature of the vitreous attachment, and that this may be found in combination with epiretinal membrane. Here's a patient complaining of decrease of vision in the left eye. We can see changes in the vitreous. On the fluorescein we see leakage from the retina on the area where there is vitreous traction, and of course on the OCT we see the hyaloid, the vitreous traction, we see what's going on, we see the splitting in the retina. I think that OCT is complementary to fluorescein. I tend to use them both simultaneously, and I think the fluorescein does have a major role to play. Here's a patient before surgery with vitreomacular traction. One can see the changes in the fovea due to the traction, and post-operatively, after we remove the traction epiretinal membrane, and I like to use a gas tamponade when I see defects in the fovea, we see visual improvement and good restoration of the foveal contour. Again, a patient pre-op and post-op, and we can really get excellent surgical results. Another example, doing a time-dependent analysis on the Heidelberg, we see the great improvement in the foveal contour. So how do we have success in treatment of vitreomacular adhesion that's causing vitreomacular traction? First of all, we should only operate on patients who are visually symptomatic. The OCT is the key to defining what the surgical approach should be. There are vitreomacular traction patients, patients with macular holes, combined epiretinal membrane with vitreomacular traction. There is myopic macular retinal schisis. In some diabetic patients, we see vitreous adherent to the macula, and there's even the question as to whether or not in some AMD patients there's a component of vitreous traction that may be participating. Here's an eye that has vitreomacular adhesion without any traction. This is a normal finding in patients when we study the vitreous carefully with OCT, but here we see a posterior hyaloid with a distorted fovea, cystic changes, and again, if you do a raster OCT scan, you can better define all of the pathology. So whatever machine you use, if it's a spectral machine, you can get many cuts through the macular area, and you really want to evaluate all of these cuts to determine the anatomy. Some of the instruments we have do